Mahalakshmi, and I would like to welcome you to iMusings. iMusings was born out of a simple belief that ophthalmology doesn't have to be complicated. When we understand the why behind what we see, the clinical decision making becomes much more intuitive. Through the iMusings, my goal is to simplify ophthalmology by combining scientific evidence with practical clinical reasoning and visual learning. Whether you are a postgraduate, student, or a practicing ophthalmologist or a teacher, I hope this every session leaves you with at least one concept that changes the way you examine a patient. Let's begin. Medicine keeps evolving. We have AI, advanced imaging, OCT, meibography, tear osmolarity, and countless diagnostic technologies. Yet, many of our diagnoses are still made on the slit lamp. That is why I created this series Back to Basics Clinical Skills. In this series, we will revisit the fundamental examination techniques that every ophthalmologist uses every day, but often without fully appreciating the science behind them. These are the skills that don't become obsolete. In fact, they become more valuable as technology advances. Today's topic is one of the simplest tests we perform, yet one of the most misunderstood one. Ocular surface staining from dye to diagnosis. Imagine a patient who says, Doctor, my eyes burn all day, but every investigation looks normal. How many of us have seen such patients? Today I am going to argue that sometimes the answer isn't another expensive investigation, it is in a single drop of a dye. By the end of this talk, I hope you will never look at the fluorescent staining the same way again. Let's look beyond the green stain and understand the story it tells. Before we talk about dyes, let us ask one fundamental question. Why does the ocular surface stain in the first place? To answer that, we first need to understand what happens long before the stain becomes visible. The tear film spreads because of the every blink which we take. This is remarkably thin but highly organized. Although it's a few microns thick, the tear film is responsible for the optical quality, lubrication, nutrition, and protection. As long as this tear film remains stable, the ocular surface remains healthy. So, this tear film is disturbed because of the triggers like environment, surgery, contact lenses, medications, and inflammation. Tear film instability occurs way before any epithelial disturbance occurs. It is the altered quantity or quality of the tear film which happens first. This altered tear film instability causes ocular surface damage, which later results in visual symptoms as visual fluctuations, discomfort, reduced quality of life. Early detection of this ocular surface staining enables timely diagnosis, treatment, and better outcomes. So the key message here is to recognize and manage the tear film instability early so that it prevents to the progression of into a chronic ocular surface disease. Suppose I give you only one dye for the rest of your career, which one would you choose? Let us see. What does fluorescein sodium do? It detects the epithelial cell junction defects and it stains best on the cornea, and it's well tolerated. It is useful for diagnosing epithelial defects, ulcers, and dry eye. Rose Bengal, on the other hand, stains the conjunctiva better, but it is more irritating. It is ideal for mucin deficiency, severe dry eye, and filamentary keratitis. Lysamine green, which is better tolerated than Rose Bengal, detects degenerated and devitalized cells, chronic ocular surface disease. There is no single dye which tells you the whole stories. Usually, the dye that matches your clinical question is the dye you should choose. Choosing the right dye always helps you to ask the right question and get the right answer. Do you know why does the healthy cornea not stain? Because it has tight junctions. The glycocalyx which is there in the hydrated mucin layer repels the dyes and pathogens, and there are gap junctions which support cell communication and tissue integrity. When this protective barrier is disrupted, the cell junctions break down, there is dye penetration and staining appears. Staining is a visible sign of barrier failure. Understanding the barrier helps interpret the sign. If five ophthalmologists stain the same patient, do they all get the same result? Usually, no. The difference is frequently not the patient, but it's the technique. What's the most important step in staining is the right amount of fluorescein. One of the commonest mistakes we use is to use too much of dye. We soak the strip in an entire drop of anesthetic or saline and paste it onto the conjunctiva. That floods the tear film with fluorescein. Instead, the strip should be just lightly moistened. A small amount of dye is all that is required. Think of it like adding food color to a glass of water. If you add few drops, it gives you a clear color. But if you put the entire bottle, then everything becomes uniformly dark. This same happens with fluorescent. Then you have to install in the lower palpebral conjunctiva. Then allow the patient to blink it few times and wait. This waiting is very important so that it allows the dye to spread and then examine. Examine the slit lamp under proper filter and document. So the common mistakes which are usually done are instilling on the cornea, using excessive dye, assessing immediately, not blinking and using the wrong illumination or no filter. The key takeaway is the right dye, right place and the right timing and the right light gives you the right diagnosis. The useful thing you have to remember in this one is a term called quenching. Do you know what it is? Do you want us to explain it more? Please tell us in the comments. The pattern recognition turns staining into diagnosis. Where the stain appears first often points out to the underlying disease. Always look at whether it is in the superior, interpalpebral or in the inferior. Look at the location, pattern and density and they all tell you a story. Mostly in the inferior it is because of blepharitis, meibomian gland dysfunction and it's superior in VKC which is predominantly under the upper eyelid. It is mostly interpalpebral in the dry eye disease and also diffuse or inferior in a toxicity with drug-induced allergy. This in drug-induced also you have a lot of conjunctival involvement of staining also seen. Focal or localized staining is usually seen in an ulcer or an epithelial defect or trauma. Staining pattern act as a clinical map guiding you to the underlying cause. Why is grading system important? Grading is always important to improve the consistency. What might be mild for me might be moderate for you and might be severe for another person. To have uniformity and also to help in research, we have various scales. Think them of like different various in which different scales on which you can do. It is important, it's not important to know about multiple scales, but it is important that in one scale, how the patient is performing today versus performing tomorrow, whether there is an improvement, whether there is a worsening, which will tell you a lot about the progression of the disease and effect of your treatment. What ocular surface staining tells us is just more than a picture. It gives us actionable clinical insights. It helps us to take up a diagnosis. It also helps us to assess the severity and also gives us a pattern which will guide us towards the underlying etiology. And it also helps us to monitor the treatment response before and after using medications. So guiding the management, staining pattern with severity will give you a targeted treatment plan which will give you better outcomes. Interpret the stain, understand the surface and improve the. Next, I want you to know about the ocular surface stress test, which is detecting the ocular surface stress. In this, we initially instill the fluorescein and carry out with the routine examination and then allow the patient to recover, ask the patient to blink normally and again reinstill the fluorescein and record the staining. You record the staining appearance before and after the tests are over and an increase in more than one grade from the baseline is considered to be positive ocular surface stress test. Comparing the baseline versus final staining is very important. An increasing staining reflects that the tear film instability and ocular surface compromise is present. Why should we do ocular stress test? Because it detects the suspected dry eye patients with normal routine tests. It helps in pre-surgical evaluation in refractive and cataract surgeries who are prone to dry eye post-operatively. It also helps to detect contact lens intolerant patients, and it helps in screening in asymptomatic high-risk patients. It assesses the tear film stability, the epithelial integrity, the ocular surface resilience, and the response to stress. When it's stable to be negative, where there is a stable tear film, that's a healthy surface, and it's supposed to be positive when there is a more than 2 grade strain increase, when there is significant instability, and then we are supposed to treat the underlying case disease before taking up the patient for surgery. All these factors like environment and all are very important and very crucial in the ocular surface stress test. And for getting the accurate ocular surface test, it is very important to standardize the lighting, to use the same fluorescent and installation technique, and maintain consistent environment, and instruct the patient clearly, and document with clearly with photographs. Another test is the dynamic ocular surface staining assessment for the dry eye. This is very important because all through we have been considering the ocular surface as a photograph, but this considered it to be a video. So in this, once when fluorescein instills and the eye opens, the tear film spreads. So the tear film breakup, observe the breakup pattern and the staining dynamics, and this will give the diagnosis. Why is it called a dynamic assessment? Because it looks at the tear film behavior and detects early instability before the extensive staining occurs, and identifies the cause to guide the targeted therapy, and it is more accurate, personalized management of dry eye. So there are three subtypes of based upon the tear film breakup pattern. In the aqueous deficient dry eye, there is immediate breakup, there is no staining, and low tear volume. Whereas in the decreased wettability type, there is a decrease in the mucin and glycocalyx layer, so there is punctate staining, poor surface spread, and irregular or patchy breakup. Whereas in increased evaporation, where there is a defect in the lipid layer, it's rapid uniform breakup with inferior staining and the signs of MGD. These all will give you the clue for the underlying disease and help in personalized management. So tear film, as you know, is made up of three layers, whereas the lipid, aqueous, and the mucin layer, and each thing is targeted therapies are available which targets around a specific layer. So each specific layer, this dynamic staining will really reveal the tear film instability early and identifies the deficient component and enables personalized management of dry eye disease. So let's go ahead with the eye musings pulse. So, staining is mostly because of the barrier breakdown, and it reflects the epithelial compromise and not just cell death. Technique of staining matters. The right time, right dye, and the right interpretation and right method are important. Pattern guides you to the diagnosis. Location and pattern point to the underlying disease. Grade also used for consistency. Use a validating grading system helps to track the trends. Stain to guide and monitor and manage. It helps us to tailor treatment and improve the outcomes. Always interpret the staining in the context of symptoms and other clinical findings. Small changes in staining can signal big changes in the disease. Repeat examination help to detect the progression of or improvement early. Documenting well is very important. See the stain, understand the surface, and elevate your care. If you want to use all the three dyes to stain, in which order will you use? Think for a while and then come back to this video for the answer. Yes, first you will do the fluorescent stain, then the lissamine green stain, and then the rose pink. Thank you for your attention, and let's see you around in the next episode of iMusics. See you again.